So I'm absolutely delighted to welcome our next speaker, who has been a beacon of light and knowledge in our online community since its very earliest days. Dr. Stephanie De Giorgio is a dedicated GP from East Kent with a profound interest in women's health and obesity management. A graduate of King's College, Dr. De Giorgio has authored vital guidelines for GPs focusing on contraception and perinatal mental health. Notably, she's an advocate against obesity stigma and has developed a comprehensive e-learning module on obesity for the RCGP and the MB Medical Obesity course. Her work with All About Obesity highlights her commitment for educating healthcare professionals on compassionate and effective obesity care. Dr. De Giorgio's insights on menopause and trending topics in women's health are invaluable. Please join me in welcoming Dr. Stephanie De Giorgio to the stage.
Thank you so much for having me. It's really nice, and it's weird. I remember those early days of 2000 and in before times, as it is now, and I found TECO's really amazing when I started being a GP, and it's lovely to be here now, and it's fabulous. So for those of you who don't know me, I am I'm a GP. I live near Dover, and I practice up in Margate, actually in an urgent treatment centre in a hospital that I swore I'd never, ever, ever again set foot in 15 years ago, and I'm now back there. Our urgent treatment centre, because we're so under-doctored in East Kent, is very much like doing GP, but with a few more sick patients. But it's really nice because I have no post, no path, no doc man, none of it. I go and see patients face to face all day, and then I go home. It's brilliant. So I used to do obs and gynae before I became a GP, and I feel really privileged to have been able to take my interest in women's health into my work in primary care. And then obesity became a really interesting specialist subject of mine. Actually, because I got really fat, I put on weight and realised that I could do everything in my life except lose weight. And that made me really unhappy. And so I went on an evidence trawl and ended up actually having metabolic bariatric surgery. And then decided, with all my learning, why not share it? And it became one of the things I do. I have a lot of cats. I have 5 cats, so I'm a bit weird. One of them is a giant cat, yeah, I'm a bit odd. But I also have 2 human offspring. They're a bit easier, and their food doesn't smell as disgusting. One is now, God, when I started all of this, one's at university now, doing biochemistry, odd child, and the other one is 12 now. She'd just been born practically when I joined TECO. No, she hadn't been born. My God. Anyway, she unfortunately now isn't very well. She's got long COVID, and so I have to be a homeschooling mother, not something I ever thought I'd do. But she has the cats, so she's happy. So what are we going to cover? Well, when I put a little thing out saying, what would you like me to teach? It was like basically a whole women's health course in a day. And I can't do that in an hour. So I'm going to use a case to kind of cover all of these things. So we're going to do starting and potentially stopping HRT. We're going to talk about how do you know this person's in a perimenopause versus just having a bad time in their life. What's the safest HRT and who can have different kinds of HRT? Tailoring and monitoring HRT, which I feel really strongly that we're GPs. Right? That's our area of expertise. And one of the things that I don't want is for GPs to feel absolutely bogged down, unless it's a specialist interest, in the minutiae of HRT. There are experts in HRT. So what we're going to go for is the stuff that we do all day, every day, that is safe and recommended for us to do. And no one gives me a microphone without me talking a little bit about obesity, so we're going to have a little bit. So our case is going to start with Amina, and we're going to talk about her and weave all of that stuff through learning about her. Because as you so rightly said, GPs really love a case study. That's what we're going to do. So she's 39 and she comes to see you because she's been feeling like the world's a bit rubbish and she's been really struggling with anxiety symptoms particularly. And it's been about 4 months. But she also noticed that her period went a bit weird about 9 months ago. It's quite heavy, and now she's missed a couple. So she's thinking, there's something weird going on in my life, and I'm not quite sure. I'm not sleeping, and she wonders whether she could be starting her menopause, because she's watched the TV, and everybody's talking about menopause, and everyone's talking about menopause at all different ages and all different symptoms. And she's right, it could be, but how on earth do we work that out? She's very young. So, what things do we need to think about? We're GPs. GP is holistic. That is our thing. We look at the whole person. So we need to think, what do we know about her history? And one of the things when I teach GP trainees or medical students who come through, I say you have to be really professionally nosy. That is what makes us good GPs. You can get most stuff in the history. So we need to ask her, when did all of these mood symptoms start? Did they start around the same time as her periods? Is there a trigger? Has there been something going on in her life that could have started all of this? Has she ever had it before? Did it, where all of this is, and really dig down into that nitty-gritty detail. And then we need to think about a family history as well. We know, for example, that early menopause tends to run in families. We know that people seem to kind of have their menopause at about the same time in different families. So, if she says, yeah, well, my mum stopped her periods at 42, then we're thinking, okay, does she have epilepsy? People with epilepsy have premature ovarian insufficiency about 10 years earlier than people without epilepsy, which was something I didn't really know until a little while ago. So there's a lot of things for us to ask in all of this. And then, should we test? So she hasn't come because she's worried about fertility. She's come, she doesn't really feel good, and she wants to know what we should be doing. So who would do a test? Who would think she's under 40, let's see what's going on? Yeah? Most of you. Who's not sure what you might test for? No? So we'd probably do 2 FSHs, wouldn't we? About 6 weeks apart. But because she's real life and not a textbook, it's not clear cut, okay? Because things aren't clear cut in real life. So what we know is that hormones do this, right? They do this. And so if we've taken her, that's why we do 2 6 weeks apart. So we know that her FSH is going above 30 at some points, right? So we know that it's probably going above 30 quite a lot of the time. But we know that it dips down as well. So she's not post-menopausal. She hasn't got, at the moment, premature ovarian insufficiency. But she is probably heading in that direction. And so we probably could say that, yeah, this might be perimenopausal symptoms. We also, because we're holistic, need to think about contraception. So we know that about 10% of women who have premature ovarian insufficiency will occasionally ovulate, which is really tough, because if somebody has POI and really hasn't been able to have a pregnancy, then we sort of have to say to them, well, you might ovulate, you might not ovulate. If you don't want to have a baby, then we should have you on contraception. If we're going to have you on contraception, what are we going to choose? It's a tough thing for us to be thinking about. So we now have a 39-year-old woman, probably in her perimenopause. We've been through her history, and we think, I don't think there's much else going on. I mean, apart from the world going to pieces around us currently, there's not much else going on. There's no particular triggers in her life. She's never had anxiety before. Mental health problems don't run in her family. So when we're making that decision, we've taken a really good history, and now we're thinking, actually, I think this probably is biological. I think we're probably thinking about menopause, perimenopause. And I think perimenopause really confuses people, When you talk to women, they say they're menopausal when they're perimenopausal, and that's not anybody's fault. It's because it's confusing. And we know that perimenopause can last a long time. You know, it can last up to about 8 years. So that cycling of hormones going up and down and up and down. And if you're someone who is sensitive to hormones, that's going to be potentially causing worsening of your mood. We know that the symptoms of perimenopause are generally caused by low estrogen, but we know that the horrible periods can make problems. There's a huge range of hormonal ups and downs that make life difficult. So, she's 39. We know, generally, that women who are below the age of 50 should start HRT if they can, if there's no reason that they can't. And the reason for that is bone health, and we need to get them to where we think naturally women should, you know, it's all very old-fashioned really. Most women have menopause at this age, but we say generally it's safe before the age of 50. But there's a lot of talk about the problems of HRT, and I don't think there's any drug, apart from perhaps the new obesity drugs, that has had as much scrutiny, bad press, good press, confusing press. It's the best thing in the world, it will kill you, than HRT. Yeah? It is absolutely, you know, when I started, I graduated in 2000, and when I graduated, HRT was everything, right? Everybody had it, it was brilliant. Women's Health Initiative trial came out, suddenly, there I was as a trainee gynecologist, and all the menopause clinics got cancelled overnight. It was so weird. It was so weird. So, we need to think about the safety of HRT. That's the right thing for us to do when we're talking to patients. And I don't know if some of you have seen the study that came out about progesterone-only contraception having the same breast cancer risks as combined contraception. And that came out a few months ago now. So, we used to think it was the estrogen that was the problem in HRT. Now we know that progesterone isn't its little benign cousin that we can just happily sprinkle over everything and put it in the drinking water. It does seem to have problems, and it's probably that estrogen-progesterone interaction that's part of the issue here. So, when people ask what kind of things are safer, there are some really good rules. We know that breast cancer is increased in HRT. We know that. The HRT, the women's, oh, my brain can't remember which one. Anyway, it comes up in a minute. So we know that breast cancer risk is increased. We know it's increased more with combined contraception than estrogen-only contraception. And we now probably need to think about the progestogenic component of that as well. For DVT, we know that there is an increased risk of DVT with HRT, and that increases with age. The thing we didn't know for a long time, because all the studies were generally done on oral HRT for a very long time, was that we can give transdermal HRT. Generally in a gel, more than a combined patch is safer. But if you separate your estrogen and your progestogen and give them separately, that's your safest way of having HRT, okay? And that's true for everybody, and that's easy, and we know that. The thing that hasn't happened yet, which we're waiting for, is a head-to-head of oral utrogestan versus IUSs. Because we did think that progesterone was this nice little benign sort of molecule. We know it's not. And we know that an IUS in the progesterone contraception study was second in the risk of developing breast cancer. So all the talk about Mirenas and IUSs being local effect only, we've all known that's a bit not true for a very long time, but this proved it, and that progesterone does go everywhere. So that head-to-head study would be lovely. If anyone feels like doing one, that would be brilliant. Any of the gynecologists in the room, love that. But at the moment, we don't know the answer. And that's probably the question I get asked most on the menopause course that we do. We don't know. But we do know that oral utrogestan, micronized progesterone, is the safest one that we have. So we need to think about that. But then, HRT, a cause of death potentially with breast cancer, although the risk of death from breast cancer is not increased by HRT. The rates of breast cancer are increased, but death from breast cancer is not increased. Mortality is not increased. And again, we need to do that brilliant GP thing that we do of taking a really holistic approach here. So we know that there are many, many causes of death in women. And actually, breast cancer isn't up there at the top. Lung cancer is the one that scares the living pants off me at the moment, because we're seeing so many young women with lung cancer being diagnosed who've never smoked. Cardiovascular disease, yes, we know that that's an issue, and we know that HRT can be implicated in that if it started too late, if it started before those plaques have been put down in the endometrium, that would be very weird, wouldn't it? In the blood vessels, then we know that HRT protects against cardiovascular disease. So it's pros and cons, and sometimes this is the thing that's hardest about discussing this with our patients. So we know that HRT actually reduces all-cause mortality. There are so many points and counterpoints for the safety and problems of HRT that it's really important we sit with our individual patients and have that discussion with them. It's quite easy for Amina. She's 39. She doesn't have a family history of breast cancer, and we know that she needs that estrogen to keep her bones healthy, so we would start her on HRT. She has a uterus, so she's going to need progestogen to prevent the problems of endometrial proliferation. We know that the safest way of giving her HRT is transdermal estrogen and then some sort of progestogen, either micronized progestogen if it hasn't run out again, or a 52 milligram RUS. We can't use any of the lower dose RUSs for the HRT component, but you can now use Levocert for the intrauterine bit, which we couldn't before. So that's quite good. And I think this is really important. This is the thing I wanted to show, because breast cancer really scares women, and that's not a bad thing that we think about the causes of breast cancer. But we have to think about all causes of breast cancer. We have to think about having overweight and obesity. We have to think about alcohol. We have to think about all of those things. And the nice thing about the risk of HRT is that it doesn't seem to be added on to some of these other risks. So if you have obesity, your risk is higher because of all the extra estrogen going around. If you then add HRT, you don't add extra risk. You've already maxed out your risk. So we're in quite a good situation. I mean, there has to be a bonus to having overweight, right? So you can have, and we know that exercise is good for us. Activity is good for us. We've always known that. And whether that lower risk is because people who do a lot more activity happen to have lower body weight and lower adipose tissue is, you know, we don't know. But we know that it's good for us. And so I think the bottom line for me when we're talking about safety is you have to take the really holistic approach with the woman in front of you and make sure that you're giving her personalised advice. I'm not going to go into all the different kinds of progestogen because there are menopause experts will tweak things slightly differently, but what we need to remember is that overall risk for our patient. So she comes back to see you, and she comes back a few years later, and actually she's having worsening symptoms, but she's been on HRT this whole time, and she's been on a normal dose. Now, I'm not here to badmouth any private clinics. That's certainly not what I'm here to do. But when you're the GP and your patient has been to a private clinic and has had a huge dose increase in their estrogen, that's then your problem to deal with sometimes. So I'm going to talk about that. So she's gone up and she's using now 6 pumps of her gel, and we're not generally kind of happy at about 4. So she's having a lot more estrogen, and she's having worsening symptoms. They haven't gone away. And this is where it starts to get really difficult. And it's particularly difficult at the moment because a huge number of people are taking more and more and more estrogen. Do we know it's safe? We'll talk about that in a minute. And if they are taking more and more estrogen, what about the progestogen? If they have a uterus, what on earth do we do? If they've got a Mirena in, what do we do? Is that enough? We know that the rates of endometrial cancer are rising, and we know that it's possibly because of the increased rates of overweight and obesity, but we have to wonder. We have to think, it's not obviously this in the last 2 years, but we have to think a little bit about it. And this is becoming news now. And this, these headlines have been there. I'm not going to talk about individuals, but there's a lot of pushback against some individuals. But then there's the other side of the argument where people are saying, I'm on 1 million pumps a day and I feel brilliant. So what do we do? Well, first of all, is it being absorbed? Transdermal estrogen is great if it's going transdermally. If it's not, then that's not particularly helpful. And most of the labels or the packet inserts and instructions tell you to put it below the waist. So they tell you, because they don't want it near your boobs, basically. That's the reason. But what we know is that everybody's bodies are different. And people hold fat tissue in different places and their skins are different. So your inner forearms, for example, are much better for absorbing than your butt. But that's where you're told to rub it. So what do we know? There are huge variations in how transdermal medication is absorbed. And so we need to be, again, that professionally nosy thing? Ask her, where does she put it? What does she do? Does she spend ages rubbing it in? Which you're not supposed to do. You're supposed to put it on like you do fake tan. Just sort of squirt it, gently rub, and then apply, and then wait. But some people kind of get a bit overexcited. But one of the best ways to think about it is to feel your skin, right? If you're like me and you're bottom heavy, and you have more fat tissue there, then that bit of you is a bit colder. So it's not going to absorb as well through cold bits of you than warm bits of you. I'm a simple person. I like simple things. So feel the bits that are warm and smear it there, but not on your boobs. Definitely not on your boobs. That's not good. Once you've done that and you've taken that history, then you think, right, should we be doing estradiol levels? Now, I've seen this creep. About 5 years ago when I taught the women's health course and wrote the book, I was like, don't do estradiol levels in general practice. And now everyone's going, should we do estradiol levels? Well, if they're doing transdermal HRT and estrogen, then you can. If they're oral, don't bother. And which should be within physiological levels, ideally. But there are people who will say they don't get a good response at physiological levels and they need higher levels. If you're getting above 800 picomoles per litre, you're in deep doo-doo world, okay? Then you're starting to think tachyphylaxis, not doing so well. Tachyphylaxis is where you start to get all the side effects from not having the estrogen, from having too much estrogen. Now, most of the studies on this are from the olden days when people used to have estrogen pellets inserted into their, under the subcutaneous estrogen. And some of those women got really, really super physiological levels of estrogen. It didn't go very well for them. Now, we don't know about the risk of tachyphylaxis, but we're kind of learning more. And if you started to get to levels above 800, then the problem is not their estrogen. There's another problem going on. And what do we do about the progestogen dose? So this is where, again, I'm talking in GP language for those of us who do GP and aren't running specialist menopause clinics. The BMS has come out with this guidance. So basically, you need to increase the amount of progestogen that you give someone if they're on sort of higher than recommended doses of estrogen. Now, someone asked me the other day whether this should be for the top line of normal prescribing. No, If they're in the leaflet, the normal recommended doses of estrogen, then probably the normal recommended doses of progesterone are okay. If they are on more than that, then while you're having that negotiation with them, keep them safe and up their progesterone, okay? What we're a little bit fuzzy about is if they have an IUS, is that enough if they're on extra estrogen? And no one knows the answer to that. If they're not sensitive to progesterone, they're okay. You could chuck a little bit of utrogestan in there as well. And I don't think that would be a bad thing to do, because you're going to keep them safe from endometrial proliferation. And the other thing, now everyone jokes that I'm very ultrasound happy because of my old job in gynecology, but there's nothing better than knowing that someone had a look. So if you can get a transvaginal, or ideally, but ultrasound to have a look, and if someone's getting weird bleeding, if there's weird stuff going on, get an ultrasound to get someone to have a look at the thickness and what their endometrium looks like, because then you know it's okay. And actually, I've been noticing more and more and more that endometrial or pelvic ultrasound is being recommended, and I think I'm kind of interpreting it as people in the know are getting a bit twitchy about these extra endometrial cancers and the increased risk, so perhaps we should be doing more. Now, I know that's hard because the waiting list for ultrasound in some places is quite long, but I think it's probably something we should be thinking about. So, when you do Amina's levels, she's putting it in the right places, it's being absorbed, and it's at the high physiological end. So you know that it's very, very unlikely, to be honest, that her symptoms are due to not having enough estrogen. So what might you do next? I will open it up to the floor. What would you do if she came to see you and you said, no, I'm not giving you more? What might you do instead?
Explore what her symptoms exactly are. So if it's just
Yep.
flushes, vasomotor, or if it's actually depression and there's something else overlying.
Absolutely. Yeah, take that history again. Start again almost. What are her symptoms? Is there something else going on? And I think that's absolutely true. So I think you'd start again with that. What else might you then feel you need to do?
Bloods.
Sorry?
Bloods, other bloods.
So yeah, so if you think something else might be going on, absolutely, has she suddenly become thyrotoxic or something strange? So yeah, absolutely, you might want to do something else, some more blood tests, look for other things. Probably, you need to start thinking about that, right? Because all of the safety data so far on HRT is in recommended doses. And I am a firm believer in HRT. I think HRT is a great thing, but I also don't think we should harm our patients trying to make them better. And I think that if people are on higher doses, it's not working, there's something going on, then we reduce that dose back down to the normal levels of safe prescribing. Because I think we are doing them no favours by potentially increasing their risk of ovarian cancer, breast cancer, stroke risk, all of those things. And this is really hard because at the moment we have some very, very vociferous HRT campaigning going on, and women are feeling that they should be given more and that this is the answer to their problems, and it probably isn't. We need to be balanced about this and think generally. It may be that you try a different type of HRT. Despite my love of utrogestan and transdermal estrogen, it might be that someone responds differently to something else. So you may think, do you know what, the risk slightly increases, but I'm going to put her on a patch, or I'm going to put her on oral HRT. And you would have that discussion with her. If there were other risks, obviously you would have to think differently. But I think, personally, I think we need to be careful about ever increasing doses. And I think if an increased dose isn't working, we should be taking that dose back down to normal, looking for other things, and thinking what else that person might need. They might need some testosterone. Now, testosterone, I didn't have time to get into a whole testosterone thing today. If you go to my NB medical course, I've written it all there for you. But British Menopause Society have a lot of really good free stuff as well, so you can have a little look. Testosterone is only licensed for low libido. There is a lot of discussion about it being good for brain fog. There's a lot of discussion about it being good for energy levels. I don't know. I think the jury's probably out there. If you feel confident to prescribe, but I know in some areas GPs are told they shouldn't prescribe, you kind of get to have a think about whether you want to do it or whether you refer for it. And it is all unlicensed, so you have to have that discussion. But some people think it's great. But I think it's really important that we need to take a really holistic approach here. Right, I'm going to go on to something not very trendy, which is local estrogen treatment. Now, this will fit quite nicely into the next talk as well, but I think it's really important because there are people who are feeling quite disadvantaged by not being able to have systemic HRT. All the talk of HRT is making some women, for example, women who've had breast cancer, feel like they aren't, like it's not fair, and all of this stuff about HRT being life-saving and will stop you getting dementia, although actually it might make you have dementia. The jury's out on that one. We need to know about the alternatives so that we can help women who can't take HRT, because not everybody can, or not everyone might want to, and that's fine. So I'm going to talk about local estrogen treatment. And we're going to talk about Ella. Now, Ella has had recurrent UTIs over the last year, and I know the last speaker's talking about that. But she's come to see you with a lot of this. And she has a lot of vulval soreness and itching, and it's like a burning, itching, unpleasant kind of symptom. She also has a sort of a watery discharge. So in her head, she thinks, well, I can't have vaginal dryness because I've got watery discharge. Actually, we know that that comes with atrophic vaginitis as well. Her sex life has gone, and that really upsets her because that was really important to her and is causing some relationship issues. And she is on anastrozole for breast cancer. So we have a woman here who wants to be able to feel better. Having constant vulval soreness, vulval itching, not being able to do the things that you want, bleeding really easily, that's miserable. So let's see what we can do for her. The first thing that we can do is examine her. And I will get on my soapbox, and you'll never get me off on this particular topic. So many women are given thrush treatment after clotrimazole, after Dactacor, after everything, right? And not one person has gone, excuse me, I think it would be a good idea to have a little look at the sore bit. I mean, that's, you know, if you teach a 3-year-old and they decide they want to play pretending to be a doctor, they look at the sore bit, right? So real doctors should look at the sore bit as well. So we need to have a look. We need to make sure she hasn't got lichen sclerosis. We need to make sure she hasn't got lichen planus. She might have recurrent thrush as well. She might have atrophic vaginitis and some of those other things. But please have a look. Please have a look. One of my courses is just a picture of a thrush, and it says, it's not always thrush. And I just want to stick that on walls in various places. So what options do we have? We have, before I go through all the different estrogens, we have vaginal moisturizers. Now, when I first heard of these, I thought, okay. But they are becoming increasingly sophisticated and very useful. There are lots of brands. Yes is a brand that is available on the NHS. You can prescribe the Yes products. And the moisturizers, generally, if someone's on a vaginal estrogen, use them on a day when they're not putting their vaginal estrogen in or their vulval estrogen in. But the moisturizers, you can't use too much, you can't make a problem. The only thing that can happen, and it's worth discussing it with someone, is that if you use a lot of it, it can form like a little bit of a plug. And so these women go, what's in my pants? I might bring it to you and show you, because that's what happens, isn't it? Anyway, it's just the moisturizers forming a little plug of goop, and then it comes out. So there are lots and lots of different types of vaginal and vulval estrogen, and I think even people who know quite a lot about menopause don't necessarily know a lot about these. We know you give some, and you might make it better, but we don't really know huge amounts. So there's two types. There's estriol and there's estradiol. And in the estriol group, you've got Avestin cream, which you can prescribe with an applicator, or you can just have the tube. Blissel gel, and that was brought out because it was a slightly lower dose, and so it was thought that it might appeal to women who have had breast cancer and are a bit nervous about using vaginal estrogen. And then there's Invagis pessaries as well. Then in the estradiol, you've got Vagirux pessaries, Vagifem pessaries. I mean, that's a really bad name. They must have sat round a boardroom table and been paid a lot of money to come up with the name Vagifem, honestly. Then there's the over-the-counter ones, and I put these in here, 30 quid a month. That's a lot of money to just save you going to see a GP, isn't it? But that was an average. Superdrug was the cheapest. And they're branded as Gina pessaries. And then there's Estrin, which is a vaginal ring, which is actually the strongest, in inverted commas, form of vaginal estradiol, and can be particularly useful for perhaps people in care homes where the GP or someone could fit the ring, and then they've got a constant supply of vaginal estrogen, which is easier than if they're not allowed to give that kind of care. It's all a bit complicated sometimes. So if you can, that might be suitable for them. And the other thing is that there isn't one better than any other. When women are coming and they're struggling with atrophic vaginitis or these symptoms, I always tend to start them on two things at the same time. So I tend to use a cream and a pessary, because the pessaries can take a little while to work. So I don't tell them to bother using the applicator that comes with the Avestin. It's really messy. I just tell them to squirt a bit and rub it around. It's that sort of easy. And because it's a soothing cream, so it will soothe that sort of inflammatory soreness, and then they can use the pessaries as well, and then they can continue the pessaries and perhaps reduce the cream. But that's kind of a good way of starting. And you can mix estriol and estradiol, it doesn't matter. I tend to do that more than just prescribe one type. If someone you think they might have lichen sclerosis and atrophic vaginitis, then I will actually start them on the strong steroid regime for the lichen sclerosis and start them on the pessaries as well. If you do start someone, just a side note on the strong steroids for lichen sclerosis, they're really likely to get thrush a lot. It can be really problematic, so prescribe them some clotrimazole to go along. And actually some people put their Dermavate or whatever it is, and then a bit of the clotrimazole and put it on at the same time, because it can be really quite problematic. So this is the biggest next question, is are vaginal estrogens safe in women with previous breast cancer? Well, overall it's considered safe. The American Obs and Gynae Association, everybody's saying it's safe. But there has been a new trial that came out last year that did show an increase in recurrence in women on aromatase inhibitors. Now, the jury is out as to whether this is something that's going to be reproduced in more trials, and people are doing those trials to see whether that's likely to happen. There has been no increase in mortality in that group in this study, but I think it's something that we need to discuss with women on anastrozole or any other aromatase inhibitor and see what they think about it. If they have horrible symptoms, which they can on anastrozole or the other aromatase inhibitors, the vulval and vaginal soreness can be like life-ruining. And so they may say, do you know what? There's no increase in mortality. Yes, I'm aware there might be a slightly increased risk, but let's do it. So, as I've said, you could notice I say this a lot, always examine them. You can choose one or the other, it doesn't matter. Combine the two, especially when you start that prescribing, because it will make that woman much more comfortable from the moment you start. And you can use vaginal moisturizers as well, but you need to use them as a different time to cream or pessaries. Okay, so I've got a really dry mouth today. Oh, okay. So you can all look at my upside down cat while we wait. He's called Remy. He's bonkers. I've never had a cat that's a Maine Coon before, and they act like dogs. And he plays fetch and stuff. It's great. Okay, now, I know this is women's health, but that's okay because women get obesity too, right? So, in fact, Tico, you said I could talk about this, so I'm going to. So, obesity is a topic that I care deeply about, and I care deeply in terms of advocating for people with obesity and overweight, and I care very deeply about ensuring that treatments can get to all people if they wish to have them, and that the healthcare system takes it seriously, and that stigma goes away. But that societal stigma is so deep that we know it affects everybody, and we know it affects healthcare professionals as well. And we know that healthcare professionals give shorter appointments to people with obesity. We know that they consider people with obesity to be weak-willed and non-compliant with all treatments, not just treatments for obesity. We know that lots of places aren't set up, so there are a lot of clinics where all the chairs in the waiting room have arms, and people with obesity can't sit down because they're worried that they can't get out of the chair again. So, I'm talking about this today because the GLP-1 medications are in the news. I thought that might be useful if I give you a little bit of a background on that. And we're going to talk a little bit about this. Now, this is, or was, a little bit, what's the word? Controversial would be the word. And it's still controversial. And I have doctors like foaming at the mouth sometimes when I teach this. But obesity is a chronic condition, if you want to call it a condition rather than a disease. And obesity is not your relationship with gravity. It is not how much you weigh. It is the fat tissue on your body and what that fat tissue does to the rest of your body. That is the condition of obesity. And it will affect people differently depending on where that fat tissue is. Now, you talked very sensibly about BMI and BMI not being ideal, and it's not ideal. And in the new NICE, well, it's not new, it's the updated version of the NICE guidance this year, it now talks about making sure that we use the adjusted BMI for people of different ethnicities. But, like so much guidelines, they've gone white and non-white, which is just crap, quite frankly. So if you go to the Canadian obesity guidelines, it is much more nuanced than that and has much better sub-breakdown of groups, and it's much better. But that's what we have in NICE, and we need to make sure that we are doing a waist to height ratio as well. So basically, if your waist is more than half of your height, then there's a problem. And the problem is that all of these measures, all that we do, tries to look for a proxy measure of central obesity. It is the fat tissue around your organs in the middle of your body that is the problem. Because visceral fat is completely different to subcutaneous fat that sits under our skin and behaves completely differently. And it is the visceral fat that is the problem. And the reason that there's different cutoffs is because people from different ethnic backgrounds deposit visceral fat differently. And so if you are South Asian, you're more likely to deposit visceral fat at a lower BMI. So we have to think about the health risks in that way. So there are medications now. And the headlines for this, it is literally the only thing that is as bad as HRT. I've had journalists stalking me because I was paid by Novo to write some stuff. And obviously that means I'm a corrupt, horrible person who needs to be put down. Actually, they were really nice to work with, and they didn't tell me what to write at all. But I've never had anyone who has written articles on heart failure be stalked by journalists in quite the same way. There's something about obesity that makes people go a bit bonkers. And it's all about the stigma. It's all about the fact that if you are fat, you don't deserve medicine. You should just try harder and it would all be fine, which we know isn't true. So, this is a table that took me a very long time to write. And I know it doesn't look complicated, but believe me. This is, mostly because I'm really crap at tables. So this is just a tiny proportion of the gut-brain axis hormones. The things that control our appetite and our satiety, our fullness, are the hormones and the reactions that go between our gut and our brain. And there's 2 centers in our brain, or 3 really, that control our appetite and our satiety. And they respond to these different things. So ghrelin is produced in the stomach. It makes you it makes you hungry, and it makes you less full. If you have bariatric metabolic surgery and they take out the top bit of your stomach where your ghrelin is made, then suddenly you're not hungry all the time. It's not that you have a tiny tummy, that's not why you lose weight, you just aren't hungry. Leptin, this is the only thing that our subcutaneous fat makes, apart from hormones, sex hormones. And so when you eat generally fat-containing foods, it's really scary presenting this in front of a nutritionist. But anyway, when you do, then your body produces leptin, and then you get less full. You then have peptide YYCK, and then at the bottom you have GLP-1. And GLP-1 is secreted from the gut, and it stops you being hungry, and it slows your gastric emptying, and so makes you feel more full. And GLP-1 is why all these drugs have been made, because someone realized you could make this. They've tried making leptin, they've tried doing all these other things. GLP-1 is the first one that really worked. So, what do we have in terms of these medications? So, at the moment, the one that is causing all the hoo-ha is semaglutide. Now, semaglutide is not new. Semaglutide we have used for a long time to treat type 2 diabetes, but then the drug companies went, ooh, it makes people thinner. We could make a lot of money here. And so they did, and they called it something else, which is very difficult if you're in America, because then you don't get insurance, blah, 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 blah. So they released Wegovy. Now, Wegovy is semaglutide for weight loss. Ozempic is semaglutide for diabetes. So they released it, and they first released it in the States, and then it all disappeared into the vortex of the United States of America, and no one could get hold of any for a very long time. But it's a once-weekly injectable GLP-1 analog. So when you take it, you feel less full. You feel less hungry. It'd be crap if you felt less full, wouldn't it? It makes you less hungry, and it makes you feel more full. And when people start it, especially people with obesity, because obesity makes you hungry because of the action of the gut-brain hormones. It's not that being hungry makes you fat, but once you have obesity, you are always hungry and never full because of the changes in your gut-brain axis. And when people start this, they go, I'm not hungry, I don't know what to do. It's really weird. And that's one of the reasons that people lose the weight, because they suddenly don't want to eat all the time. And it is a life-changing moment. And if there's ever anything that talks and teaches about the biology, it's not that people are gluttonous, greedy, whatever. It's that they have been so hungry all the time, and now suddenly they're not. And they don't suddenly go, oh, I'm still going to eat everything. They generally don't. Some people don't respond to GLP-1s, which is interesting. There's a sort of a subgroup of people who don't. And it does loads of things to people, and there's some really interesting research now on heart failure. It improves HFpEF, so heart failure with preserved ejection fraction. It improves quality of life on those. And it works because of all of these things. So in your ARGP center, in your brain, you basically, you go, oh, I'm full. And then you go, oh, because I'm full, I don't need to eat again. It does decrease gastric motility, and that's where some of the side effects come in. And there are some anaesthetists who are going, if you want a GLP-1, even if it's privately, could you let me know? Because someone starves for 24 hours, they then do the anaesthesia and because all their dinner from 2 days ago is still in their tummy. Not nice. So fess up. If you're on a GLP-1 and you talk to an anaesthetist, just let them know, because you have to starve for longer preoperatively. Because the side effects tend to be GI related, which is not surprising because that's what it works on, people have to go up the doses. So you start in a low dose and then you go up the doses a month of each dose. Now at the moment you can't get above 1 milligram very easily in the UK because it's all still in America and they can't make it fast enough. But that's kind of where things are going at the moment. And it works. It really works. And it works, it's about a 15-ish% loss of body weight, which is a significant health improvement. Your blood pressure, your lipids, your pelvic floor incontinence, your life generally. It might mean you can shop in shops that are not specialist shops. There's a lot of things that can really change for this. And so I am an advocate for these because it changes people's lives, quite literally. And then this big thing has been made of the fact that the weight goes back on when you stop it. But we know with diet and exercise, 92% of people will put all of their weight on by 5 years that they've lost, right? So it's the same as diet and exercise. It's the same. And so what we need to remember is that people aren't suddenly scoffing, I don't know, McDonald's and fish and chips and Chinese takeaway when they stop it. The physiology of obesity means that when you lose weight, your body goes, well, that was a crap idea. And it upregulates your GLP-1, it downregulates your leptin, it changes your CC, your peptide YY. It does all these things to you so that you are more hungry, you are less full, you get more reward from bad food. It upregulates your hedonic hunger, the hunger that allows you to eat past the point of being full. Unfortunately, it doesn't say, yes, you're going to get more reward from food, and that food is broccoli. Doesn't do that. You get reward from beige food and fat food and carbohydrate food. So your body makes you put that weight back on again. And to work against that, you are working against really primal physiology. So if people do keep it off, they've done an amazing job, like an amazing job. But that's why it's only about 5% of people. And there's a lot of research looking at why those people can keep the weight off. And it's not because they're better than the people who can't. Something else has generally gone on. So at the moment, people can only get this on the NHS for 2 years via a tier 3 weight service, of which only 50% of the population has access. And at the moment, none of them are prescribing Wegovy. Brilliant. But what you will find is a lot of people are getting it privately. Would that be true, young man? Yes. And someone didn't believe me, so I Googled Wegovy or semaglutide privately. And, you know, there's a lot of adverts for it. And some places are ethical, and they want to make sure that you don't have an eating disorder. They want to make sure that you have a BMI that is raised. They want to make sure that you are not doing this in a way that's going to cause you harm. Other places just want your credit card details. So there is a real risk for our patients who are taking this privately that they might become quite unwell if they're taking it without a lot of weight to lose. And if no one's looking after them, that's not ideal. We know that some people, particularly on the higher doses, start to get a really, really reduced appetite and they forget to eat. Now, if you are someone who has obesity, you never forget to eat. That's just not a thing. I used to look at those people at school and go, wow, they're not hungry. How can they forget to eat? Anyway, but people forget to eat, and their food intakes becomes tiny. So we should probably be thinking about people having supplements and a multivitamin and treating them in the same way as we do people who've had bariatric metabolic surgery, because we really need to make sure that these people aren't becoming malnourished, which is a real risk if you're not eating enough food. So if you are prescribing it privately, or you have patients who go, oh, you look a bit different last time I saw you, ask them. People don't tell their doctors because they're worried about judgment. People don't share that they've been on this medication because the stigma is such that if you go on it, people will go, oh, you should have just tried harder, eat less, move more, all of that. And funnily enough, for lots of people, that doesn't work. It's not that easy, but this does. And we've got more coming. So we have tirzepatide, which is Mounjaro for obesity, for diabetes, which was approved by the MHRA about 4 or 5 weeks ago now, I think. And then I can't remember the brand name for weight loss. But this works on 2 different gut-brain hormones and gets you to a weight loss of about 20%, which is metabolic bariatric surgery levels of weight loss. Hugely life-changing and potentially, life-changing. Again, you stop it, the weight goes back on. That's the same with everything apart from metabolic bariatric surgery. With tirzepatide, some of the research from the States is that people are actually becoming malnourished because their appetite has become so small. So I think it will take about, I'm giving it a month before this is available privately for weight loss. I reckon it's going to sneak in via something, and people are going to be going, yep, we'll have some of that, please. And then we have retatrutide, which is even better. It's a triple agonist, and that's 24% body weight. So we are entering a completely new world of medications. So far, we've had Orlistat, which does nothing except make you poo yourself. So we now have useful medication, and we can't pretend we don't. Whether people believe in it or not, literally people get in my face over this. Whether you believe in it or not, it's here. It's going to be here. For patients for whom it works really well. It's about 300 quid a month. It's not cheap. People are spending their money they don't have on this because they are so desperate for it. So we are entering a new world of obesity treatment, and we need to know about it because our patients will be taking it, whether from us or somebody else. Okay, that is it. A whirlwind of hormones. I hope it was helpful, and I'm very happy to take any questions.